We're going to talk a little bit about arthritis. I didn't bring a PowerPoint. I've done that, and I think that's boring for you guys, for me to sit here and flip through a bunch of slides and just kind of talk. So I like it to be a little bit more interactive. I'm going to tell you about arthritis, what it is, how we treat it. I'm going to try to do that reasonably quickly and let you guys ask whatever questions you want to know. So I answer what you want to know about arthritis, not what I think you should know. Some of you guys I know are patients of mine already, so y'all may have heard some of this if you've seen me for knee or hip arthritis, but we'll go through it for those who haven't and then answer whatever questions you guys might have, okay? Do y'all have a preference whether we talk about knee or hip? More knee, more hip? Hip. Hip. All right. We're going to do both. We're going to do both. So, but I'll start with the hip. The interesting thing is I probably see 65–70% knee arthritis as compared to hip arthritis. It's just more common. So knee arthritis is a more common problem, but we'll talk about hip arthritis. So I'm not an artist, but I'm going to draw a little bit because I think it helps y'all understand what we're doing. I'm better at knees, so I usually start with knees as far as drawing goes. So the hip, you've got your leg bone, okay, that comes up. And it's kind of shaped like this. Yeah, a little bit. All right, so this is your leg here, okay? This is the ball, and then there's a socket, okay? So the ball fits in the socket. And this is your hip joint, okay? So the biggest thing I think about arthritis is it's probably the most misunderstood word that we deal with in my office. So what is arthritis? It's really just wearing out of that joint, okay? So it's like wearing the tread off the tires of your car, okay? This has padding in it, so when your hip moves, it doesn't hurt. That padding is called cartilage, okay? That cartilage wears away for one of really two main reasons, and when it wears away, that is arthritis, okay? It is not like pneumonia or bronchitis. It's not something you catch. It's not something that your person sitting next to you is going to give you today and you're going to go home and get it in your shoulder and then your elbow and then in your knee and then in your hip, okay? Most of what we see is, there's kind of two forms here, but most of what we see is what we call OA, or osteoarthritis, or wear and tear arthritis, okay? That's the most common form. That's probably what most people sitting in here have. There's one other type of arthritis, and we'll call it IA for now, but it's called inflammatory arthritis. Those are the two major categories, okay? You got one or two of those. Osteoarthritis is just, I put too many miles on my hip or knee joint and they've worn out and it hurts, okay? Inflammatory arthritis is I have rheumatoid arthritis, I have lupus, I have gout, I have one of these systemic problems that my body's own immune system typically attacks my joint and causes the same problem, tears the cartilage up. So the end result is the same. The padding is gone, okay? The process to get there is either I wore it out or my body has done something to my joint to make it wear out, okay? And that's as complicated as it needs to be, okay? The cartilage, so we talked about there's a padding or a cap on the end of the bone, and there's a padding inside the cup. It feels pretty good when the padding's there to move your hip and walk around and sit Indian style and sit on the floor and get up, but when that wears out and the bones start touching each other, it hurts, okay? Your cartilage, the padding has no nerve endings in it, so it doesn't hurt when it moves. When it wears away and the bones start rubbing together, it hurts. Your bone has nerve endings in it, and it causes pain, and it sends a signal to your brain that says you probably shouldn't be doing that, okay? Yes, ma'am.
About what age?
Well,
Yeah.
it really is very patient dependent. So I will see a lot of 60-plus-year-olds in my office today that'll have arthritis. But I've already seen 2 early 40-year-olds in my office that had complete bone-on-bone arthritis today.
My daughter was 26.
Yeah, now that's very early. That's typically caused by some other problem. Either she had an injury to the joint or there's some other reason that her cartilage, yeah, fast wear and tear. So how do we treat these? Well, really, it's very similar in how we treat these. So step number 1 is medicines, okay? So here it's what we call NSAIDs, which are just, I left out an I. I don't spell well. Non-steroidal anti-inflammatories. These are your Motrins, your Advil, your Aleve. There's prescription forms of those called Celebrex, Mobic, diclofenac, okay? Those are medications that are designed to just calm inflammation. When the cartilage wears out, the bones start rubbing together, your body responds to that by creating some inflammation. It pumps extra fluid into the joint trying to lubricate it, and it causes an inflammatory response that makes the lining of your joint then hurt too, okay? These medications calm that down. You can also use those over here for the inflammatory arthritis. And then there's another medication, and we call them DMARDs. Y'all don't need to know these names, but these are medications that modify your immune system. So if your own body is destroying your joints, these are the medications that we put rheumatoid arthritic patients on, okay? So step number 1 is medications. What's the problem with this? Well, most of you guys sitting in here probably don't just have knee or hip arthritis, right? You have hypertension, or you've got diabetes, or you've got heart conditions, or you've got other medical issues. Well, we've learned over time that these medications can interact with those problems. So if you have diabetes, that affects your kidneys. Well, these medications can affect your kidneys. Not a good medication. If you have high blood pressure and heart disease, you're probably on aspirin or some sort of blood thinner. Can't take that with, or this medication with those. We think it may increase your risk of heart disease to some degree. I'm not sure I believe that, but that's a different discussion. But most of my older patients, and again, most of my patients are older, these medications aren't good. Now, these down here, if you're rheumatoid, are okay. So most people, when they come to see me, this is not a great option for them. Okay, now the 26-year-old or the 40-year-old that I saw today, this was a pretty good option for that patient, short term. But if you take these every day, year after year for years, you can get stomach ulcers from them, and they can affect your kidneys. So we don't do it the way we used to. 20 years ago, if you'd seen an orthopedist, you would have got put on one of these and they'd tell you to take it every day and we'll see what happens. We don't really do that anymore, okay?
Portions of this program are brought to you by Fairview Park Hospital, a leader in healthcare for Dublin-Lawrence and surrounding communities, providing specialty services through facilities such as our Sleep Center, Heart Center, and Women's Imaging Center.
To better serve our members, Altamaha EMC has opened a new customer service office in East Dublin. The office is located at 679 at Beckham Road, open 9 a.m. to 4 p.m. Monday through Friday. We also have a night drop and kiosk machine for after-hour payments. It's convenient, it's safe, and here for you. Altamaha EMC. Stop by and see us today at 679 at Beckham Road in East Dublin. Altamaha EMC can be reached at 912-526-8181. Community owned, community built, community builder. Altamaha Electric Membership Corporation.
Step 2, which is where most people are at by the time they get to see me, okay, is injections. And this is all true for knee and hip arthritis. We'll talk about the knee a little bit more specifically, but these treatments are the same. So what are injections? Well, there's cortisone injections, which is the most common, okay? Cortisone or Depomedrol is what we use in our office. Some people use something called Kenalog. They're steroids, okay? Steroids are anti-inflammatories. You take steroid and you put it in a joint and it calms inflammation and swelling and pain, okay? It's like taking this medicine, making it a little bit stronger, putting it in a liquid and sticking it in your joint. It works well, okay? What are the downsides of this? And I get asked that every day. Well, doc, I hear that if you inject it, my bones are going to get softer and I'm going to have problems and it's going to lead to worse arthritis. And the reality is that's just not true, okay? Oral steroids, so if your doc puts you on prednisone and you take it by mouth and you take it for a while, it can do those things. It can soften your bone. It can affect your own body's production of steroids, and it has side effects, okay? You don't want to be on steroids long term unless you just have to be. But injecting them in your joint does not do that. Yes, ma'am?
I have a question. What do you think about the Voltaren
Voltaren
peel?
pills, okay, oral pills is this. So it's an anti-inflammatory. It's very similar to Motrin, Advil, Aleve, Mobic, Celebrex, all the same. It is an older anti-inflammatory or non-steroidal anti-inflammatory. It's okay. It works for people. It helps calm inflammation, but it has all of those potential side effects that I just talked about. Yep. So diclofenac has been around a long time. It's cheap. Most insurances will cover it. The VA loves it. So everybody I see from the VA that has arthritis is on diclofenac. It's kind of their anti-inflammatory of choice. There's nothing wrong with it. You just got to monitor for those side effects that we talked about. Now, they do make something that I'll use sometimes in people who can't have these, okay, and they've either had this and it didn't work, or for some reason they can't have injections. They're allergic, some bizarre reason. They make diclofenac in a cream form. So they basically take the medicine, grind it up, make it into a compounded cream. It actually will absorb through your skin, and it helps with inflammation. If you do it that way, not as much of it gets into your bloodstream, so it doesn't have as big of an effect on your kidneys, and it has no effect then on your stomach. So we'll use that sometimes, but its effectiveness is probably not as good, okay, as taking the pill. As long as your medical doctor is aware and you're monitoring for those potential side effects, it's not that you can't take those medications. It's okay to be on them. You just got to be aware of what the problems can be with them. And that's with any medication. But she was saying she'd been on Mobic, and then her doctor swapped her to diclofenac. Same type of medicine. They're both non-steroidal anti-inflammatories, okay? But sometimes if you've been on any medicine for a while, your body gets sort of used to it and processes it differently and maybe chews it up a little too fast, and you swap to another one, and it may work for a while. Again, temporary, but it may buy you time, and that's okay. You just got to be aware of the potential side effects from it. Tylenol arthritis is just a extended release Tylenol. So it's Tylenol that they make it where it's slowly released into your bloodstream, so you get a prolonged effect of Tylenol. Tylenol is a pain reliever, so it helps reduce pain. It doesn't calm inflammation in any way, but it may help control some of your pain. So Tylenol arthritis is pretty safe, something you can buy over the counter and use and see if it works. If it works for you, great. So back to injections. Cortisone injections is typically a lot of times the first line treatment that you get from me, because we're already past this up here, okay? You've either been treated by your medical doc with these, or you can't take these, or there's reasons I don't want to give them to you. If you have inflammatory arthritis like rheumatoid arthritis, typically your medical doc has already sent you to a rheumatologist and you're already being treated with medicines like Humira, or there's hundreds of rheumatoid medicines now. Injections typically is what a lot of them are. We moved to injections, so cortisone injections is the number one that I do as an anti-inflammatory. We do knee injections in the office. You don't have to have anything special to do knee injections. I now do the hip joint's deep. You can't really feel it very well. It's hard to make sure you get a needle down in it. We've got an ultrasound machine now at the office, so I'll inject hips with cortisone under ultrasound, okay? Again, it's temporary. It calms inflammation, makes it feel better. It does not fix it, okay? It's not fixing the fact that your cartilage is gone.
Can I ask another
Sure.
question? The hip pain, does it's in my groin real bad.
Correct.
I mean, I can only walk at times, getting up, because
Yep.
I got so much pain.
Yeah. So what are the symptoms of hip arthritis? Okay, since we're kind of focusing on the hip. A lot of people come in and say, Doc, my hip's killing me. You know, I hurt right here and hurt down in my leg. Probably not your hip. Most likely your back. Okay, it's nerve pain. True hip arthritis, true hip pain typically hurts in the groin. It's deep in the groin. It hurts with movement. It's worse with activity. It typically, at least early on, will feel better with rest, so it gets a little better. You sit down and rest, although you might get a little stiff too. And then you get up and try to move, and it hurts. It stops you from doing things like lifting your leg up to get in and out of the car or walking up and down stairs. Knee pain, obviously, it hurts just in the knee, in and around the knee. People don't generally get knee pain confused with anything else, but hip and back pain, there's a lot of crossover. You can get some arthritic pain in the back of the hip joint, kind of in your buttock region, but if you come in telling me you hurt in your buttock region, the first thing I'm thinking is it might be your back and it might not be your hip. Now, if I get a hip x-ray and your hip's shot, we might talk about it differently. There's one other problem in the hip joint that we'll see that can give you a lot of pain in the groin. It acts just like hip arthritis. It's called avascular necrosis, okay, or AVN. It is a loss of a blood supply to the ball of the hip joint up here and causes the hip to kind of collapse down, and then you get arthritis, okay? There are things that lead to that. People who take a lot of steroids, we were talking about prednisone earlier and it having side effects, so prolonged use of steroids for things like asthma, lung problems can lead to avascular necrosis. Alcohol use, so heavy alcohol intake, people that drink every day can get avascular necrosis. People with sickle cell disease, so that have a clotting disorder, can get it. And then the most common reason is what we call idiopathic, meaning we're not smart enough to figure it out. So we don't know what causes it, so it's called idiopathic. That's the most common cause of it. The end result is a bad hip, just like arthritis, okay? But the ball collapses down some in that particular problem. With hips, cortisone injections help some. They don't work as well as they do in knees. So if you've never had a cortisone injection for your knee and your knee's pretty arthritic, it probably works pretty well to start with unless you have really severe disease. The hip is more of a 60%, 70% success rate maybe in giving you pain relief. This temporary though, right? All of these injections, they might work for 2 days, they might work for 2 months, they may work for a year. And some people, they don't work at all. You don't know till you try them. We typically do it because we're trying to put off the next step, okay? When you've been through medicines, you've been through injections, and those don't work, then we get to step 3. Now, if we're talking about knee arthritis a little bit, there's one other type of injection for knees that we do. It's commonly called like rooster comb shots or gel injections. We call them viscose supplements. It's kind of the generic medical term for it. It's a lubricating type injection for the knee, okay? It was initially made from rooster combs. That's why some people call them the rooster shots or chicken shots. It's a gel-like injection that you inject into the knee. We had hoped it was going to rebuild cartilage when they first found this substance, but it just doesn't do that, okay? It calms inflammation, it calms pain down, but it doesn't regrow cartilage, okay? A lot of insurances don't cover it anymore, so if you have a Medicare replacement plan, it may or may not cover it. Straight Medicare pays for it still, but they're one of the few. Some of the Medicare replacement plans do. A lot of the private insurance carriers do not. Blue Cross Blue Shield absolutely will not pay for it. That's just kind of a stance they took in the end of 2017. The reason some insurance companies don't cover it is it works about 60% of the time. So it it helps people when it works, but 40% of people that get it get no relief. So you can understand why an insurance company says, well, that's not real great odds, we're not going to pay for it. The people it works for, it works great. They love it. It lasts a little bit longer than cortisone, but it's a bit of a coin toss of whether it's going to help you. It's only approved for knees, not approved for hips. So it's off-label to use it in hips, although I know some folks that do, it's not suggested to. Okay, so that's the second type of injection, cortisone, and then the gel shots, if we're talking about knees, really for hips is just cortisone injections.
Imagine a life-changing injury. Imagine the fear and unknown. The Houston Clinic Sports Medicine Team, the only physicians in the area with advanced certification in orthopedic sports medicine, treats sports injuries with innovative techniques. The Houston Clinic has helped nearly 1 million athletes live without pain. Imagine getting back in the game. Imagine the best game of your life. The Houston Clinic Sports Medicine Team.
The way the world is today,
Go! Go, go, go!
things just seem so out of control. That's why the things we can control are so important. That's why we're members of our electric co-op. The whole reason the co-op exists is to bring us the electricity we need. So they look out for us. They invest in the best technology you can get, just to keep the power on. Not because they have to. They actually do it because it's the right thing to do.
Step 3, which nobody really wants to get to, but it's what we do a lot of, is what we call TJA, or total joint arthroplasty, or a hip replacement and a knee replacement, okay? What do we do when we do that? Well, in the hip, and this is end stage, okay? You failed all these other treatments, we can't make you feel better. You're still hurting in your groin, you're still hurting in your knee, you have pain with activities, you can't do the things you want to do, it's impacting your life and you're tired of it, okay? This is the fix. All these other things that we've talked about from in step 1 and step 2 make people feel better. They do not fix your arthritis, okay? Even though cortisone makes your knee feel better, it's not making the cartilage regrow in your knee, okay? I want to talk a little bit about joint replacement. I want to back up one step because there's one other thing that I get asked a lot about now, and it's stem cells, okay? So it's a hot topic for a while. It's died down a little bit, but what are stem cells, and do they help with arthritis? Well, stem cells are cells in your body that can become anything, okay? They're cells that, if you take them from embryos as they're developing, they're cells in an embryo that then can become cartilage or bone or hair or any organ in our body, okay? So for a while, we've tried to come up with ways to take those cells and grow things that we need, cartilage, organs, yada, yada, yada. Y'all know all the controversy that goes along with that. But as far as knee and hip arthritis, you can take stem cells by harvesting fat from people's abdomen. So you get liposuction, essentially, which a lot of my patients say, hey, I can sign up for that. You get basically liposuction, where you suck some fat out of people's abdomen. Everybody has some, even if they're thin. You suck it out, it goes through a processing machine that filters it, and it takes out stem cells, okay? Fat stem cells. They're not cartilage stem cells, but they're stem cells nonetheless. And through a filtration process, you get some stem cells and some other anti-inflammatory mediators that are in that, and you inject it back in the knee, most commonly done for knee arthritis. What does it do? Well, step number 1, it does not regrow cartilage. Okay, everybody thinks, okay, I'm going to go get stem cells injected in my knee or hip, and it's going to reverse my arthritis and make cartilage regrow in my knee and hip, and I'm going to be great. It does not do that. Okay, it calms inflammation. It works in a different way than the cortisone injection, but it doesn't regrow cartilage. It's not going to take your x-ray that shows bone-on-bone arthritis And 2 years from now, you're going to come back and I'm going to go, wow, this looks like a 25-year-old hip. It doesn't do that, okay? But that's the misconception and why people are willing to pay what they're willing to pay for it. Because the other catch with this is insurance companies do not cover it, and you have to pay for it out of pocket. And it's somewhere, the cheapest I've ever heard of it being done, and that's usually if you're having more than one joint done at the time, is about $4,000 per joint. If you're having one joint done, a lot of times it's $7,000 to $10,000 to have that procedure done where they take the cells, filter them, and then re-inject it in your knee, okay? It can be done in an office setting, a semi-sterile sort of setting. A lot of people do it like at their surgery centers, but it's an all-cash deal.
How long does it last?
Well, we don't know really, because like the gel shots that I was talking about, it doesn't work for everybody. So I've had a few patients that were just really wanted to see what it would do for them, even after I explained to them it's not going to regrow your cartilage, but it may work and it may buy you a couple of years. Go get it done and it didn't help them at all. So a few months later, they're back in my office, you know, $7,000 out of pocket, and they're saying, Doc, it didn't work. I don't feel any different. But some people get years of, 1 or 2 years of improvement of their symptoms. There's not good data for me to tell you a number what the average length of this working is. There's not a lot of studies on it. There's not a lot of people paying $7,000 to have it done. But it is out there. It's being done. The biggest misconception, though, it does not regrow cartilage. So it may work for you, and I'm not telling people not to try it. I mean, I've looked into doing it. I just don't have enough people in the patient population that I treat that want to pay $7,000 to have me do that when it may not work. And especially once they know it's not going to change the end game probably for them. It may put it off for a few years, but it's probably not going to keep them from having to go to a joint replacement eventually. Okay? And most people say, well, I'd rather spend that $7,000 on my joint replacement and my deductible than having it done. But it is an option, and it's out there.
Do you have an age of the joint replacement, age limitation?
I don't. So that's been kind of over the years as well. My so-and-so, my niece went in and she was 40 and she was told she was too young to have a knee or hip replacement. We don't like to do knee and hip replacements in people really young, okay? We like doing it in people that we think we're going to be able to do one joint replacement and it's going to last them their lifetime, okay? Which means if we can get you into your 60s, you probably are going to get by with one joint replacement if everything goes well and it lasts. Joint replacements early on would wear out in about 10 years, okay? The plastic, and we'll talk about how they're made, but the plastic is what would wear out. So we were really not wanting to do them in people, that were not in their 60s and 70s even. Now lifespans now are getting longer, right? So most people are living into their 80s. But our joint replacements are also lasting longer. So the plastic that we put in there, and there's a plastic piece in a knee and a hip replacement, and I'll talk to y'all about that. I should have brought one over here. That is lasting longer. We figured out better ways to manufacture and make the plastic so it holds up longer. We don't know how long they're going to last. You'll see commercials on TV telling you they're going to last 30 years. We don't know that to be true. The new plastics have been out about 16, 17 years now, maybe 15 to 17 years, somewhere in that ballpark. And they're holding up very well. They're lasting longer than the previous generation plastics, but we don't know if they're going to last 20, 30 years. That's just us predicting how long it's going to last.
The older you get, the longer it takes for you to recover, right?
Well, there's two sides of that. So the younger you are, the easier the recovery is. But the older you are, the less demand you're going to put on it and the longer it's going to last. So there's a balance there of when's the best age for me to have it done. Well, that's different for everybody. You don't want to wait until you can't walk, you can't get around, your muscles are weak, and your health is bad and you're not a good candidate for surgery. But you would rather not have it at 40 if you can help it. But to answer your first question is, I don't really have a specific age limit. It's different for every patient. I've operated on people close to 90 for joint replacements. I don't advocate that for everybody, but there's some, and y'all know this, there's some 88-year-olds that act like a 60-year-old. They're healthy, they don't have any medical problems, they're active, they're driving, they're doing activities, they're playing golf. That's a different 88-year-old than the 60-year-old who's got heart disease, in a wheelchair, and doesn't walk. So I've done them as young as people in their 20s on the hip side for things like avascular necrosis. It gives me heartburn to do that because I know it's not going to last that patient very long, but sometimes we don't have a choice. So I don't have an age number per se, it's dependent on the patient.
Yeah, that's what my daughter had, was that necrosis.
Correct.
And her second one, her second hip replacement, I understood they used titanium or something.
Well, most of the metal pieces now are made out of titanium or titanium alloys as opposed to cobalt chrome, which is what we used to make most of them out of. But that doesn't necessarily change the length of how long it's going to last. There's different bearing surfaces which we can talk about in hip replacement specifically that may change the length, but we're talking about not huge differences in the length that's going to last.
Hi, I'm Taylor Knight, here to put our team at Community Bank to work for you. Teamwork is vital in sports, at work, at home, and community. That's why we worked so hard to establish a winning team of customer service and lending professionals. When you call on Community Bank, we stand ready to help. There are other banks, but there's only one Community Bank. So come see us and let us put our team to work for you. Community Bank of Dublin, Lawrence County. Common sense banking never goes out of style.
Oh, hey, you got one of those insurance apps too? You know how this thing works?
No, sorry. Not an app, it's my agent.
In this moment,
No, I'm fine, thanks.
it's good to know you have a trusted, independent auto owner's insurance agent who's there when you need them.
Great.
Man, I gotta get one of those.
Or Insurance in Dublin is your local independent auto owners insurance agency.
So osteoporosis, I'll talk about real quickly, wherever it is, and it's a completely different problem from arthritis. It doesn't cause arthritis. The two aren't connected at all, okay? Osteoporosis, and it's common in women. Postmenopausal women, it happens in a lot. It's because of the hormone changes. And it's a softening of the bones, essentially. So our bones have little, if you look at the inside of a bone, if you could cut it open and look at it, it has bone inside of it. It looks like a sponge, okay? And those little, it's got spaces in it, what we call marrow, and then it's got little bony connections, little pieces of bone that are crossing and going everywhere and connecting. And what happens is that bone gets softer, and so it becomes easier to have things like fractures. And that's why we are so nervous when older people fall, is because, well, their bones may be softer, which is osteoporosis, and they may break easier. Osteoporosis in and of itself is a medical issue. It's treated typically with medications and injections to try to increase the quality of your bone, how strong your bone is. It does not really affect knee and hip replacements a lot. If you have really severe osteoporosis, we worry a little bit about the pieces of knee and hip replacements, the metal pieces loosening from your bones if you have really, really bad osteoporosis. You can imagine if you've got a bone that's like a really soft sponge now and you're trying to attach a metal piece to it to replace a knee or hip joint, it's harder to do that if the bone's really, really bad. Now, it has to be pretty severe osteoporosis before I get really nervous about a knee or hip replacement not working well for people. Yeah.
Which have you found?
Yeah.
Which have you found to be easier to get over, hip replacement or
Hip by far.
hip?
Mm-hmm. The knee replacements are painful. The physical therapy, the physical therapy is intense, and you got to do a lot of physical therapy, bending and straightening right away. There's not a lot of tissue around our knee. You know, I mean, most people's knees are fairly thin, and there's not a lot of tissue around it. So when it swells and it gets tight, you don't want to bend it and move it. You want to hold it still. If you don't move a knee replacement right away, it will get stiff really quickly, and you get a result you don't want. Okay. Hips don't really get stiff a whole lot. The physical therapy is not near as intense with a hip replacement, so the recovery, believe it or not, even though it's a bigger joint, a little bit more work to put a hip replacement in as far as dissection and stuff, it's not as painful of a recovery as a knee replacement. So what do we do when we do a hip replacement? So the ball's bad, right? The cartilage is worn out. This is no longer space, it's just beat up. So we come in, I shouldn't tell you all this, you would never probably have it done. I'm gonna draw this a little bit better because it looks more like this. We cut the bone here. Well, we dislocate your hip first, but you're asleep, you don't know that. So we cut the bone there, and basically we take this out. Ball's gone, the bone now looks like this, and we throw the ball away. We send it off to pathology and they destroy it and it goes away. The cup, we then use these things that are kind of like cheese graters, and they spin on a drill, and we clean the cartilage out. We basically are scraping the bad cartilage and the bone that it's attached to away. So we make this deeper and scrape it away, and then we put a metal cup in here, okay, that wedges into place. Sometimes we put screws in the cup into the bone to hold it a little bit better. If your bone quality is really good, I typically don't do that. That cup has a roughened surface on the back of it, and your bone grows into it and locks it into place, okay? We then snap a plastic liner into that cup, and there's different types of liners. There are some that are made of ceramic, but I'm not going to get into the details of that. But there's a plastic liner that snaps and locks into that, okay? That plastic liner, or polyethylene really, acts like cartilage, okay? We then put a metal stem down inside your leg bone. It's not curved. Like this, that wedges into the bone. Again, it's got a rough surface on it. It kind of sticks in place to start with because it's a tight fit and your bone grows into it. It has what we call a neck on it, a piece that comes up like this. And then we put a ball, usually a metal ball. I feel like I'm like my kids, like doing art. We put a metal ball on top of that that goes into the cup. And that's a hip replacement. It's four pieces really. A stem that goes in the leg bone, a cup that goes in the pelvis, a plastic liner that goes in the cup, and a ball. And that's a new ball and socket joint. So the bones are no longer rubbing together. You got metal typically in a plastic liner, pain goes away. Are there risks? Sure. Infection, pieces can loosen from the bone. You can crack the bone when you're putting these pieces in. All those risks are low, but they're real. If it happens to you, it's a problem and it's stuff that we have to address. Doesn't happen real often, but it can. That's why surgery is not risk-free.
Do you have a limp?
Hopefully not. Can you limp after a hip replacement? Yes, there's reasons that can occur. Some of that can be muscle in nature. Some of that can be the way you let your hip get so bad before that you learn to walk with an abnormal gait and it's difficult to get you out of that. Some of it is a true limp because of weakness, and muscular weakness, which we try to fix with physical therapy and strengthening. Most people do not, but you may limp for other reasons too. A lot of people that have arthritis in their hip or their knee also have some in their back. So people's backs can be arthritic. That can cause them to kind of limp or move side to side when they walk. So yes and no. Most people, I will tell you, don't have a limp after a hip replacement because of the hip replacement.
Is there a reason to do a partial replacement anymore, or you just always do the whole thing?
Yes, there's a couple of reasons where we don't do the cup side. So what we call a hemiarthroplasty or a partial hip replacement, where instead of doing all of this, we do the stem. You got the cup here the way it normally was. We haven't deepened it. And you put a bigger metal ball in here that just goes into your cup, so we do nothing to the cup side. The only reasons we really do this now, avascular necrosis, remember we talked about the 26-year-old that loses the ball. the ball's starting to collapse down, but the cup still looks good and the cartilage in the cup still looks good, I will do this occasionally in that patient population to save their bone of their pelvis, because I know they're going to have another surgery down the road. So that way, when they wear the cartilage out in their cup, I can go back and put a cup in, and it's the first time they've had a cup, so I've saved some bone in their pelvis for a while. Because you run out of bone here. Way before you run out of bone redoing hip replacements, the problem becomes the cup side. You run out, there's lots of ways we can get fixation in your leg bone. There's not a lot of bone in the pelvis to start with to work with, so you want to save bone up there if you can. Also do this in the 75, 80-year-old that falls, breaks their hip, break it here, they don't have a lot of arthritis, or they're not in real good health and we need to make their surgery as short as we can, get them in and out of the operating room. We'll do this sometimes, what's called a partial hip replacement.
Hi, I'm Helen Powell. Been serving the Middle Georgia area since 1985. If you would love an exciting career, please call me. Careers in Cosmetology, 129 North Franklin Street, 272-1967.
Hi, I'm Ashley. I'm an upcoming graduate from Careers in Cosmetology. It's been a wonderful experience, and I encourage you to contact Ms. Helen Powell for more opportunities.
Hello, I'm Christy at Careers of Cosmetology. I've recently enrolled here and I'm excited about the opportunities that lie ahead.
Hey, my name is Daphne Jackson. I'm excited to be enrolled in Careers in Cosmetology. If you would like this opportunity, contact Careers in Cosmetology.
Hi, my name is Caitlin. I've been enrolled in Careers in Cosmetology for about 4 months now. I'm really enjoying it, and I think if this is the career for you, you should definitely come see Miss Helen Powell.
Careers in Cosmetology, 129 North Franklin Street. Our number is 272-1967. Give me a call.
Hi, I'm Perry Williamson. We've been serving the Dublin Lawrence community for over 90 years here at Williamson's Bakery. We specialize in donuts, cakes, pies, cupcakes, cookies, birthday cakes. They're our business, not a hobby. And don't forget our large selection of cheese straws. For special orders, contact us on Facebook, Instagram, or better yet, just come get you some. When you stop by, be sure to try our all-new Pig in the Blankets. We have bacon, sausage, and chicken. We're located at 1634 Veterans Boulevard, Dublin, Georgia. For the hot, freshest donuts, come to Williamson's Bakery. We proudly support our area athletics.
So this is what a knee looks like. So this is your upper leg bone, okay, up here, what we call the femur. This is the tibia down here. Just like in the hip, you have cartilage on the ends of these things that normally takes away pain when you walk, lets your knee move freely and doesn't hurt, okay? That wears out just like in the hip, and if we've gone through that same process and we're to a knee replacement, what do? So we go in, and we cut the bone. All right, I'm going to draw this bone twice because this bone from the side looks kind of like this, your upper leg bone, okay? The tibia doesn't look a lot different. It's kind of, that's backwards. The tibia looks kind of like this from the side. Okay, so this is looking at it from the front. This is a side view if you're looking at it from the side. What do? Well, we basically, on the femur side, we go in and we cut the bone across here to get back to a good, healthy surface. And when we cut it from the side view, it looks like this. We cut it here, we cut it here, and we cut it here. And we take away that bone and bad cartilage, okay? The tibia, we cut flat across the top. So we cut it like that. And we take that away, okay? Just like we did in the hip. And then the femur, which is the upper leg bone, then has a metal piece that is shaped like that on the back side, but it's rounded on the front. It's made to fit you, and it looks sort of like this. And that's metal, okay? The tibia, the same thing. So this goes away. And then I should have drawn that in another color, but I'll draw it in another color on the tibia. It's a metal tray that has what we call a, that's not pointed, but it's called a keel or a little piece that goes down inside of the bone. It kind of looks like this. And here it looks flat across the top, and it has a little stem on it that goes down inside the bone. This piece is shaped very similar to the native end of your femur. It's kind of like this. It's a piece of metal. You got to remember it looks like this on from the side view. So they're caps essentially for the bone. They, unlike the hip, which I told you wedges into place and the bone grows into it, they make knee replacements like that. They just don't work real well. We've had a lot of trouble getting that to work. So most people still take these pieces and cement them to the bone. So we mix a liquid and a powder together. It makes something what we call bone cement. It's kind of like grout or concrete or glue, epoxy glue. You put it on the bone, you put it on the metal piece, you put them to, you put it on the ends of the bone. It hardens in about 10 to 14 minutes, and voila, the pieces are attached to your bone. Okay. Then there's a piece of plastic that locks in between these two. So there's a piece called polyethylene that's kind of shaped like this. It's kind of dished on this view. That acts like cartilage. So again, two metal pieces, a plastic piece. Your kneecap, which sits right here in the front of the knee, we actually flip it over. If you look at the kneecap from the side, when we're done with it, it's kind of shaped like this. We cut the back of it off, and there's a plastic button that goes on the back of the kneecap that slides up and down. So we resurface the bones and use metal and plastic to replace it. It takes, again, the pain away of the bones grinding together. Both of these surgeries, knee and hip replacements, take an hour or so to do, hour and a half, depending on how bad it is, how much work you have to do.